Imagine looking at two 15-year-old patients, right?
Right.
Both of them have the exact same medical diagnosis.
Right. On paper, they look identical.
Exactly. And based purely on the name of that condition, you might assume their futures look, relatively similar. But when we look at the data, one of those teenagers is statistically expected to live about 13 more years,
Yeah.
and the other expected to live 55 more years.
It's staggering. I mean, that's a gap of over 4 decades, and it's entirely dependent on just two very specific functional abilities.
It really is. So, welcome to the deep dive. Today, we are opening up the clinical files you provided on cerebral palsy, or CP. You sent us this massive stack of historical records, clinical checklists, hard epidemiological data. And our mission today is to really dig into what is given in these sources to understand the reality of this condition.
Right. Sticking strictly to the facts we have in front of us.
Exactly. And whether you are using this to catch up on neurodevelopmental disorders, or you're just intensely curious about how medical science actually works, understanding CP provides this brilliant window into how medicine corrects its own historical blind spots.
It's a perfect case study in clinical deduction, really, because for centuries, physicians were looking at the devastating physical effects of CP, but completely misunderstanding the biological mechanics driving them.
Yeah, they were totally off base.
Completely. And we're going to trace that timeline today, strictly following the data you've provided, to see how that murky picture eventually crystallized into the rigorous clinical standards that doctors use today.
And I think we should start right there with that historical confusion. Because when you read through the ancient texts, and our sources show descriptions of CP going all the way back to ancient Egyptian, Greek, and Roman writers, the medical community was just entirely conflating cerebral palsy with poliomyelitis.
Right. They thought CP was polio.
Exactly. They just lumped them together.
And, I mean, from the perspective of a physician in antiquity, or even someone operating in the early 1800s, that conflation is completely logical.
Oh, totally.
They were judging disease purely by its external presentation. Both CP and polio cause these debilitating, highly visible motor conditions in children.
Right. You see a child struggling to walk and you just group it all into one box.
Exactly. When a doctor saw a child with profound weakness or paralysis without the benefit of, an MRI machine, functionality was literally the only metric available to them.
Reading this, I kept thinking of an analogy. It's like looking at a massive software crash and a completely shattered physical screen on a tablet.
Oh, I like that.
Right, because in both scenarios, the tablet is totally useless to you. The outward failure looks identical. But the origin of that failure is entirely different. One is a coding error buried deep in the operating system, and the other is just, smashed hardware.
That analogy maps perfectly onto the neuroanatomy. Perfectly. And making that exact distinction, separating the software from the hardware, that was a monumental breakthrough that happened in 1889.
1889, yeah.
Yeah, a physician named William Osler published a monograph that clearly delineated the two conditions based on where the neurological signal was breaking down.
Okay, so how did he map that out?
Well, he identified that cerebral palsy is an upper motor neuron condition, meaning it originates up in the brain, whereas polio is a lower motor neuron disease originating down in the spinal cord.
I really want to pause and break down that upper versus lower distinction because looking at the files, it seems to be the key that unlocks this entire condition. How does that biological mechanism actually work?
Okay, so think of the upper motor neurons in your brain as the brakes on a car, and the lower motor neurons in your spinal cord are the engine driving your muscles.
Okay, brakes and engine. Got it.
So in polio, the virus destroys the lower motor neurons in the spine. It kills the engine. The muscle gets no signal at all, which results in flaccid paralysis. The limb is loose, floppy, completely weak.
Right. But in CP, the damage is in the brain, the upper motor neurons.
Precisely. The engine in the spine is still running, but the brain's brakes have been cut.
Oh, wow.
Yeah. Without those upper motor neurons suppressing and regulating the signals, the spinal cord just sends constant, unregulated firing down to the muscles. And that leads to spasticity muscles that are rigidly flexed, tight, and basically fighting against each other.
That is a massive conceptual leap, proving that you can have severe weakness stemming from two entirely different ends of the nervous system. I mean, that basically paved the way for modern neurology.
It really did.
But Osler wasn't the only one trying to map this out. Looking through the historical timeline in your notes, another name keeps popping up a few decades earlier, William Little.
Yes. William Little.
Yeah, in 1862, he published a paper linking a specific pattern of CP to birth injuries.
Right. He specifically focused on spastic diplegia, which is a subtype of CP that primarily affects the legs, causing them to be incredibly tight and rigid.
Right, the spasticity you just mentioned.
Exactly. Little observed this presentation and correlated it strongly with traumatic events occurring during labor and delivery. And because he was the first to formalize this link, the condition was actually widely referred to as Little's disease for decades.
Oh, interesting. So the early consensus among figures like Little and later William Gowers and Osler was that CP was basically a mouth trauma disease. They believed it stemmed from a lack of oxygen anoxic events or infections happening right around the time of birth.
Yes, the core idea that the injury occurred early in development was correct. They had the timeline right. But what they lacked was a comprehensive pathological framework. They knew CP wasn't polio, and they knew it was linked to early life, but they were still treating infantile cerebral paralysis as a singular event rather than a complex spectrum of disorders.
Which brings us to perhaps the most unexpected character in this entire historical transcript. I mean, I did a double take when I read this.
I know exactly who you're going to say.
In 1897, a researcher stepped in to review the available literature on CP and ended up fundamentally changing how we classify the condition. And that researcher was Sigmund Freud.
Yep.
Wait, that Freud? Did his framework actually hold up?
It really did.
Yeah.
I know, it's wild to think about. Long before his name became synonymous with psychoanalysis, Freud was a highly rigorous neurologist.
Right.
His 1897 review of the CP literature was incredibly methodical and yielded two profound insights. First, he looked at the term infantile cerebral paralysis and realized it was scientifically hollow.
Meaning what, exactly?
Well, it was merely a clinical description of symptoms, not a specific pathology or a specific cause.
Ah, okay. So he saw that the medical community was just using the label as a placeholder.
He did. And his second contribution completely shattered William Little's birth trauma model. Through his analysis, Freud identified that congenital brain abnormalities and hereditary factors were deeply involved in CP.
So it wasn't just birth trauma.
Exactly. He deduced that you couldn't blame every case on a difficult delivery. There were neurological issues developing in the womb long before labor ever began.
And to organize this, he created an etiological framework, right? Breaking the causes of CP into three distinct categories: congenital, birth injuries, and acquired injuries occurring after birth.
Yes, and that three-part framework was an astonishingly accurate piece of clinical deduction. It maps almost perfectly onto the congenital versus acquired frameworks that neurologists use today.
That's incredible. But as brilliant as Freud's framework was, reading through the sources for the early 20th century, the momentum seems to, stall out. The notes refer to CP during this era as a useful administrative term.
Yeah.
I mean, that sounds so bureaucratic and detached from actual patient care.
It does sound cold, I agree. But practically speaking, it was a necessary bridge.
How so?
By grouping various non-progressive brain abnormalities under one administrative umbrella, the medical community could finally organize specialized care. It allowed them to direct clinical energy toward developing targeted orthopedic and physical therapies for these children, even if the exact microscopic brain lesions weren't fully understood yet.
Right. You need a category to fund the care. But you can't truly optimize that care without tracking large-scale outcomes. And that leads us to the massive data boom of the mid-20th century.
The longitudinal studies.
Yes. Between 1930 and 1950, researchers Crothers and Payne conducted a landmark study at Boston Children's Hospital. They evaluated 1,821 cases of cerebral palsy and personally tracked 467 of those children over 2 decades.
Tracking the natural history of a condition over a 20-year span, I mean, that shifts the entire field.
Yeah.
You go from relying on anecdotes to relying on hard, verifiable data. You finally get to see what actually happens to these children as they grow into adults.
And this explosion of data coincided perfectly with an institutional awakening. In the late 1940s and early 50s, we see the founding of massive advocacy and research organizations.
Right.
There's the American Academy for Cerebral Palsy in 1947, the United Cerebral Palsy Association in 1949, and the Spastic Society in Britain in 1952, which is known as SCOPE today.
So Freud gave the field its conceptual framework, and Crothers and Payne provided the longitudinal data. But these institutions, they provided the financial and societal momentum.
Yeah, the funding.
Exactly. They concentrated research funding and public awareness, transforming CP from that vague administrative label into a heavily researched, actionable medical discipline.
And thanks to that institutional momentum, we now have the hard epidemiological data, the sources you provided give us a very clear picture of who gets CP today.
Let's get into the numbers.
Yeah. The overall incidence is approximately 2 cases per 1,000 live births. That makes it the single most common neuromotor disorder in childhood.
2 in 1,000 is the baseline, yeah.
Oh.
But the data reveals a massive variable, and that is gestational age. Prematurity is the single greatest risk factor for developing CP.
And the numbers on prematurity in these files are just staggering. In very premature infants, the incidence climbs from that baseline of 2 all the way up to 40 to 60 cases per 1,000 live births.
It's a 20 to 30-fold increase in risk, which really highlights just how vulnerable the fetal brain is during those final weeks in the womb.
Why is it so vulnerable then?
Well, the blood-brain barrier in a premature infant is incredibly fragile, meaning any physiological stress, whether it's a lack of oxygen or systemic infection, can cause catastrophic damage to the developing white matter of the brain.
Which brings us back to the stark reality we opened the show with. We have to look at the data on prognosis and life expectancy, because the clinical notes make it abundantly clear that life expectancy is not dictated merely by the presence of a CP diagnosis.
No, not at all.
It is dictated by 2 highly specific functional factors: mobility and feeding ability.
The clinical reality is that function drives prognosis. Always.
Let's lay out those numbers again for context, because this totally reframes how we should look at CP. It's not just a binary, you have it or you don't. The specific functionality is literally life or death.
Yeah.
A 15-year-old with CP who is immobile and requires tube feeding has an average life expectancy of 13 additional years. But a 15-year-old who is ambulatory, they can walk and can feed themselves, has an average life expectancy of 55 more years.
The reason for that massive discrepancy comes down to how secondary complications cascade through the body.
Right.
If a patient is immobile, they're at a much higher risk for severe joint deformities, fractures, and pressure ulcers.
Yeah.
And if they cannot swallow properly, which remember is fundamentally a motor control issue, they are at extreme risk for aspiration pneumonia.
Or food or liquid enters the lungs.
Exactly, and that causes lethal infections.
Yeah, and aspiration pneumonia is listed right at the top of the leading causes of death here, alongside other pulmonary infections, urinary tract infections, and sepsis. The source also notes that mortality is driven by seizures and, well, as these patients age, heart attacks and strokes.
We also have to factor in the specific subtypes of CP, because the data shows that the dyskinetic subtype carries a significantly higher mortality rate compared to the diplegic, ataxic, or hemiplegic subtypes.
Okay, let's quickly decode those subtypes for clarity, just based on what's given here. Hemiplegic affects one side of the body. Diplegic mostly affects the legs. And ataxic involves severe balance and coordination issues.
Right.
But what is it about the dyskinetic subtype that makes it so much more dangerous?
So dyskinetic CP is characterized by constant involuntary writhing movements. Because the muscles are continuously firing without the patient's control, their baseline metabolic rate is incredibly high.
Oh, wow.
Yeah, they are burning massive amounts of energy just sitting still. Combine that constant movement with severe difficulties in swallowing and feeding, and the risk of fatal aspiration or severe malnutrition just skyrockets.
That makes a lot of sense. The source also points out that being female, having cognitive impairment, and having epilepsy all correlate with higher mortality. But there is a crucial framing point in your notes that we absolutely cannot overlook.
Which is?
Despite all these extreme risks, CP is fundamentally a lifelong disorder. It is not a fatal childhood disease.
Exactly. The majority of individuals diagnosed with cerebral palsy live well into adulthood. And that reality shifts the burden directly onto the clinicians. Because functionality dictates lifespan, catching neurological deficits early and intervening with physical therapy can literally save a patient's life.
Which perfectly transitions us into the final section of our deep dive, the clinical detective work. Because catching those deficits requires an exhaustive, highly systematic evaluation. How does a doctor today actually track this down?
It starts with the clinical history, long before the doctor even touches the patient. They systematically review the mother's pregnancy, looking for illnesses, maternal medical conditions, and exposure to illicit substances or prescription medications.
And I see here they also specifically screen for any history of decreased fetal movements.
Yes. A sudden drop-off or long-standing lack of movement in the womb is an immediate red flag for fetal distress or an evolving neurological deficit. The baby isn't moving because the motor signals are already failing.
Wow.
Yeah. And then the clinician will lock in the gestational age and birth weight because, as we saw in the epidemiology, those are the strongest predictive data points available.
Right. Next, they scrutinize the labor, delivery, and neonatal course. They're hunting for any perinatal event that suggests a hypoxic ischemic injury, basically, when the baby's brain was starved of oxygen and blood flow. A classic example given here is a placental abruption requiring an emergency C-section.
And if the baby was premature, the clinician looks for a history of massive systemic shocks in the NICU. Did the infant suffer an intracranial hemorrhage, seizures, respiratory failure?
The notes also specifically list necrotizing enterocolitis, severe jaundice, sepsis, and meningitis. But, I find it fascinating that a doctor evaluating a brain disorder is looking so closely at an intestinal disease like necrotizing enterocolitis, or NEC.
It really speaks to the fragility we discussed earlier. NEC is a devastating infection of the intestines. In a tiny, premature infant, a severe infection in the gut triggers a massive systemic inflammatory response.
Okay, so the inflammation spreads.
Exactly. Those inflammatory proteins travel through the bloodstream, cross that fragile blood-brain barrier, and damage the brain's white matter. A shock anywhere in the infant's body is a threat to the brain.
That is terrifying, but it makes perfect sense. So once the history is mapped out, the doctor evaluates the developmental trajectory. They track the child's skill acquisition across motor, language, and visual domains. They need to know if the child is making gains, plateauing, or, most terrifyingly, losing skills they had already acquired.
A regression in skills is a massive warning sign. Remember, CP is defined as a non-progressive injury. The initial brain damage does not get worse over time.
Right.
If a child is actively losing developmental milestones, the clinician has to consider that they might be looking at a progressive neurodegenerative disease, not CP.
Okay, so the history is established. Then comes the actual physical exam. The clinician assesses limb deformities, spinal curvature, joint range of motion, muscle tone, strength. But when they're examining infants, they pay special attention to unintegrated primitive reflexes.
And this takes us right back to William Osler's brakes and engine analogy. Babies are born with automatic spinal reflexes, like the Moro or startle reflex, that help them survive early on.
Right, those little jerky movements babies make.
Yeah. And as a healthy baby's brain matures, the upper motor neurons learn to suppress or integrate those primitive reflexes.
But if a 6-month-old infant still exhibits reflexes that should have vanished at 2 months, the doctor knows the brakes are broken. The mature brain signals just aren't reaching the spine to turn those reflexes off.
Precisely. The physical exam is essentially a process of observing the hardware acting up because the software isn't regulating it.
So when a doctor is looking at a jump gait or tightly flexed wrists, are they basically looking for the physical echoes of that original brain injury we talked about earlier?
That's a perfect way to phrase it, yes. You see that misregulation most clearly in posture and gait. The clinical notes describe children with CP often exhibiting flexion at the elbows, wrists, and fingers with internal rotation of the shoulders.
So their arms are tightly pulled in.
Right. And in their legs, you see flexion at the hips, knees, and toes, with the hips pulled tightly inward. When clinicians observe how they walk, they're watching for specific patterns caused by that spasticity, like toe walking, a crouched gait, or a jump gait.
The actual brain damage may have occurred months or even years prior in the womb, but this tight, spastic muscle is the living echo of that silent event.
Exactly. The muscle itself is perfectly healthy. It is just responding to a broken neurological signal. And measuring the intensity of that broken signal brings us to a tool specifically mentioned in your sources, the modified Ashworth scale.
Which clinicians use to grade spasticity by measuring the resistance to passive muscle stretch.
Right. And because the source material doesn't provide the exact grading numbers, we won't invent them here. But fundamentally, when the doctor physically takes the patient's arm and tries to straighten the elbow, the modified Ashworth scale provides a standardized way to grade how aggressively the muscle fights back against that movement.
It translates a feeling into a metric.
Exactly. It takes the subjective feeling of muscle tightness and turns it into an objective clinical metric, allowing doctors to track if the spasticity is responding to physical therapy over time.
It's incredible how every single step of this clinical checklist is designed to catch the echoes of a neurological misfire before it permanently locks a joint in place.
It has to be that rigorous. The stakes are too high.
Absolutely. Well, looking back at what is given in the sources you shared with us today, we covered a massive amount of ground. We started in antiquity, where the medical world was fundamentally confusing the spasticity of cerebral palsy with the flaccid paralysis of polio.
Hmm.
We watched William Osler map out the neuroanatomy of upper and lower motor neurons and saw Sigmund Freud rigorously define the condition not just as a single birth injury, but as a complex interplay of congenital and acquired factors.
We then saw how massive longitudinal studies and institutional advocacy in the mid-20th century transformed CP into a data-driven field. And we learned that while prematurity is a massive risk factor, a patient's long-term survival is ultimately dictated by their functional ability to walk and feed themselves.
Which is exactly why the modern clinical exam is so rigorous hunting for primitive reflexes and spasticity to intervene as early as humanly possible. CP is the most common childhood neuromotor disorder, yet because it is not a fatal childhood disease, it affects millions of adults who are living full, complex lives today.
Exactly right.
As we wrap up, I want to leave you with a final lingering thought based on the data we unpacked. If the difference between a patient living to age 28 or living to age 70 is almost entirely dependent on maintaining the functional abilities to eat and move, how much more of our societal energy should be shifted toward developing adaptive technologies and fully accessible environments for adults with CP, rather than treating it strictly as a pediatric medical issue?
It is a vital question. Medical science has spent over a century learning how to accurately evaluate the child. But we often forget that our ultimate goal must be designing a world that supports the adult they will become.
Sometimes to move forward, you have to look past the initial diagnosis, step into the muddy waters of the clinical history, and start listening for the echoes. Thanks for joining us on this deep dive.